NHS Trust before Christmas. We've already had a busy morning discussing a whole series of different medium-term plans and issues we are addressing, but had a really uplifting session for members of the public to be aware of on EDI and our internship programme. Some absolutely class-leading, wonderful work going on within Worcestershire Acute, supporting particularly younger adults with special educational needs to get internships within the Trust and to start to achieve some wonderful things in their own life journey. And I just want to again thank members and colleagues who are supporting those younger adults to do that type of work. It really is wonderful stuff. So big shout out to everyone. So without further ado, we will get into the main body of today's board. And we have apologies, I'm aware, from Ali and Dame Julie Moore. Have we any other apologies, Joe?
No, passed to me, Chair.
Okay, thank you. So any new declarations of interest? Can you raise a digital hand for me, please? Can't see any digital hands raised. So we'll move on to the minutes of the Worcestershire Board meeting held on the 14th of October. Were there any points of accuracy on those which colleagues would like adjusted? If you could raise a digital hand for me, please. Neil.
Yeah, thank you, Chair. Under the finance section on page 2 of the report, there's a statement in there that I don't quite recognise. I'm not sure I've said it. So the Trust must deliver 4% cost and productivity improvement annually for the next 3.5 years to achieve break even. It's not factually correct, and I'm not sure I said that. I'm happy to refer back to the recording, but I'd take that out, please, if that's okay.
Does sound like the type of thing a chairman might say, and if so, I apologise if I got the numbers wrong. I thought my numbers were slightly low. Why don't we just take that sentence out, Neil, and then it's more factually correct. Thank you, Neil. Any other questions? Sorry, any other statements of factual accuracy? Okay, and as Joe has made clear in the minutes, all of the action points arising are completed, so thank you. We then got the Foundation Group 4 board meeting minutes from the 5th of November. Were there any accuracy points on those from this board? Could you raise a digital hand for me, please? Again, can't see any hands raised, and the action points from that meeting will be held over to that next 4 board meeting in March. So, without further ado, I think we're on to the Chief Executive's report. Stephen, we are suffering very heavy demand at the moment, and just before I ask you to give us an update, I do want to apologise to members of the public and families who are experiencing longer delays than we would normally want you to experience, and are experiencing corridor care on occasion for us to try and provide the safest service possible. We did in our workshop this morning discuss the variety of actions we're doing in terms of corridor care. And I also want to have a big shout out to our frontline teams, who I know at this time are working incredibly hard as ever to deliver the best care they can. And I'd like to thank all of the family members for colleagues in the Trust, because behind the scenes, it's often families that provide unseen support and hugs and kisses and care and general encouragement when people get home after a tough shift. So thanks to all the family members as well. Stephen, without further ado, over to you.
Thanks, and I'll move around the report, take that as read, but just to put some more context to some of this and pull out some important points. So on the bit that I have mentioned about flu and urgent care pressures, just to kind of bring that to a reality for the board, particularly at the Worcester Royal site, we've seen on 4 separate occasions, and the peak of it being yesterday, times when we've hit over 300 attendances, which is really significant just for that site. So that's exclusive of the Alex as well. We hit 342 yesterday, which is our highest on record. So underneath that as well, the last 8 days have seen a 16% increase compared to the same kind of period last year. And that kind of equates to 42 patients attending a day, which in itself can be significant. Split out, we've seen a 16%, so that's 31 patients a day increase in those patients that are walking into the department. And over a bigger period, we've seen a 14% increase of that group that walk in. Interestingly, and something that we will be picking up internally and with system partners, is the key periods actually appear to be happening between 11 and 1, and then another peak around 5 and 6 for that walking activity. So we will get under the skin of that, work that through. Again, just to bring that out though, because there's a lot of national media about flu, and that clearly is having an impact for us. But we are seeing that impact not just in those flu attendances and what we're managing, but that is definitely felt in primary care and the knock-on onto us. So from last year, we're seeing falls up 150%, confusion up 106%, and what's classed as generalised weakness 46%. And we talk a lot around frailty, which we should do because that's a big driver for us. But if I look at children as well, children are really up significantly. So we've got, for example, difficulty breathing up 25%, vomiting up 190%, abdo pain up 104%. We have got some big numbers in there that is driving the demand that we need to really get on top of and drive that improvement. If this is a crucial period as well, so I would be remiss not to take the opportunity. The flu vaccine is having a dampening effect, so we will see an increase in those attendances and admissions, but it definitely has an impact. So if there's a possibility of you getting a flu vaccine, to either members of the public or our colleagues, please get it. We're running up to that crucial 2-week period into Christmas, so I really want to take the chance to plug that one. Mentioned about this morning, we did a big session on the medium-term plan and how that is looking for us. So I've put some detail in there around the ask of us as a trust and how that will link to others. I think there's a real shift now and a couple of bits that I just want to draw out. In terms of the planning, it's a really significant shift and a really welcome one for us that we're now moving off 1-year plans and moving to a 3- and 5-year timeline. Gives us much more opportunity to do that proper strategic thinking about services and how we organise them and how we develop them. The 3-year plan that we will be putting in, that we started to go through this morning in the workshop, particularly around our finance workforce and the operational performance. The other bits I just want to draw out, there is a definite shift from kind of being held accountable at system level to much more of a focus for us as a board around the performance of the trust and working with regions directly really to deliver on that, and particularly around the return to a lot of the constitutional standards and performance standards that we were used to in the past that are detailed in the report. There's some really important finance information as there about our productivity improvement that we have to achieve, the financial position of the trust, which we are really well sighted on and keep really close to. And a key part of that is the exit from deficit support funding. So this is the money we receive to plug that gap that we've got, and we've got a real intent over the medium-term financial plan to exit out of that. Couple of other bits in terms of digital. There's an awful lot happening in that, and I've put more from our great teams. We've rolled out our ePMA system, which will really contribute to the safety. These things are always a little bit clunky. We really appreciate the time that both the digital team and, as we refer to them, Team Orange, and the support that they wrap around our clinical services, but the clinicians as well have been, in terms of getting the training, embracing it, working through those areas, and I know I've been feeding back where it's a bit clunky, where we might need to just keep an eye on it. So there's an awful lot of work gone into that. And the other one that we've planned, and I know this is close to your heart, Chair, we've got a clinical summit arranged where we want to really engage with clinicians, not so much on the admin side, which we've talked before about, but on those AI tools that clinicians may be wanting to use or are using in their specialties, so that we can really start to encourage that and really drive at that in the coming year at pace. because that will really deliver a lot of productivity and efficiency, and actually in a lot of cases real clinical safety improvements that are really important to us. And finally, on more from our great teams, I've not put it in the report because it came later, but it's definitely worth a massive shout out, is to our neurology team. So we've had some exceptional feedback on the work that they've done, and the reductions in their waiting list is stellar. So there's really, really good work going on there. So I wanted to take the chance publicly to thank them. Happy to take any questions.
That's great. Thank you, Stephen, and thank you for your leadership. Any questions or perspectives to Stephen on that overview? Otherwise, we'll dive into the detail of the integrated performance report. Pretty obvious one, this one, Stephen. What's worrying you most at the moment?
God, there's a list. No, the big things really are that UEC position and the patient experience of people either generally waiting wherever, whether it's waiting for discharge, corridor care, how we're managing ED, how we support our staff through that. So that's one worry. And then how we manage to do that. We've got big financial pressure, but we don't want to take our eye off the ball as well on those other things like cancer and elective. It's too easy to kind of move around all of that. So I think it's just helping us navigate the teams through that and try and deliver the best we can for the patients.
Thanks, Stephen. And next week we've got another planned resident doctors strike. I know we're doing a lot of work behind the scenes to make the experience for resident doctors working in Worcestershire more fulfilling. Could you just give us a flavour of some of the things we're doing to help our resident doctors?
Yeah, so there's, I think we brought it before, and at People and Culture, we got a really good update on what's called the 10-point plan, which is really looking to improve the working conditions and the work-life balance of our resident doctors. So there's an awful lot of work, particularly focused on things like rest facilities, the work that we can do around that to help, and linking in around how we can structure their rotas and do things like that and support them from a trust point of view. So we will be bringing that back to the trust board, but yeah, there's a lot of work, not just, I think a lot of the focus is on the financial side of it, but there's an awful lot of work we need to do to improve the working conditions and lifestyle that goes around those resident doctors.
That's great, Stephen. Thank you. So we'll move on now to the integrated performance report. And again, Stephen, do you want to do a brief introduction, then we'll dive into the detail?
Yeah, just really briefly, and just it links all of these things together. So we've talked about that urgent care pressure. We know we've got capacity open that we really wouldn't if we were in a better place. That can drive our temporary staffing spend, and a lot of that UEC unplanned is really what's fundamentally driving some of our financial challenges that we have to get under the skin of and drive at. We are making some good progress in some of those areas. So our agency bill has come down quite dramatically. That's countered with we've effectively switched it to bank use, which is better both from a quality and a finance point of view, but we know there's a lot of work that we've got to do there. They were the main bits. I just wanted to just make sure that that golden thread went throughout. I'm happy to hand over to executive colleagues.
Okay, that's great. Well, first up on quality and safety is Hayley. We've got apologies from Jules, so I'll allow you to cover the whole gambit. Hayley, over to you.
No, thank you. I've also got Ed as my wingman, who's Jules' deputy, on the call as well. But from my perspective, I just want to flag three things really, and then I'm happy to take any questions. So as you said this morning, we've had a board workshop about our additional spaces, so our corridor care. It's also known as temporary escalation spaces or planned escalation beds. And you'll see in the pack we are now absolutely tracking those, and they're very, very visible at board. And what we will see in the forthcoming months is how we're triangulating that with our performance as well. So that's in terms of that element. The second element is regarding IPC. So infection prevention and control, we are continuing on our IPC improvement journey, if you like. We are seeing an increased number of flus within the organisation. We've got circa 44 today. So it is gradually creeping up day on day. Our flu vaccine programme is well and truly en route. We've got circa about 40% of our staff that have been vaccinated, with an ambition to go a lot higher. We're also vaccinating our patients who've been in hospital greater than 21 days. In terms of our IPC, what's been really evident is the IPC team and their visibility and their support with our operational management, because we're an organisation that don't have a lot of side rooms, so we have to use our side rooms really sensibly. Therefore, to enable to create flow, we are absolutely, our IPC colleagues are working hand in hand with our operational colleagues. We've also updated elements of our policies to ensure it's really easy to use out of hours in terms of who requires side rooms, and also what type of clean is required following a patient being discharged from a bed with a certain infection. And the last thing from an IPC perspective, as you know, we had an IPC visit for our regional teams back in May, where we were placed on intensive monitoring. We then had a third review in September, and we are placed on enhanced monitoring, because we saw some real improvements and real engagement. Last week on Thursday, we had a visit from Kirsty Morgan from the region, a supportive visit to the Alex, and it was really positively fed back in terms of engagement and processes. And then we've got a formal in January. And the last thing I just want to raise is our complaints work. We're not where we need to be with our complaints target. We're just over 62%. However, we have really reviewed how we are managing our complaints in terms of that initial contact. I think Karen or Catherine may have mentioned that last time that we had public board. So we've really tweaked that process and making sure that we're capturing that. And part of that initial contact is being really clear what our complainants want us to answer and agreeing those timelines. And we're also pushing to have more and more face-to-face meetings where possible, because that to me is the way forward. And if that's what our complainants want, that's what we're also really advocating for. And finally, as you know, I oversee complaints, and the content and the detail that are going into the complaints, I think they're really improving. Notwithstanding, we've still got a way to go, but I feel that they are of a higher quality. And that's it really. So I'm happy to take any questions unless Ed wants to talk about NOFs. Thank you.
Thank you. Ed, apologies for not realising you were on the call. Ed, anything you'd like to add on quality and safety?
No, I think Hayley's covered it all really. Our NOF position again is not fracture neck of femur, just for members of the public, is not where we want it to be. We saw some good improvements. We reorganised the trauma ward services at the Worcester Hospital in the autumn, which showed us a great ability to bring patients over from the Alex who had suffered fracture neck of femurs and operate on them sooner. That improvement hasn't been sustained in quite the way we'd hoped, so we're just looking to see why that is and trying to re-establish better control over the workflows of patients coming particularly from Redditch and over to Worcester to be operated on for their fracture neck of femurs.
Ed, thanks Ed. Any questions to Hayley or Ed? Simon?
Thanks, Chair. Hayley, anything with the complaints in terms of trends or themes that we ought to be aware of that might be concerning you?
I wasn't on mute, it would help. We are seeing obviously some challenges with weights, and that's either predominantly weights in our ED department, which we've talked about within previous boards, and weights for appointments, but nothing particularly, Simon. But we will bring an update of the Q3 complaints report and patient experience report to Quality Governance Committee, where any trends will be flagged. But thank you.
Thanks. And Karen?
Thanks, Chair. Hayley, again, I just wanted to come up on complaints, and it's great to hear that you're happy that the content of the complaint letters and responses are improving. And I'm curious about, I noticed, I don't know if I'm missing a page, but I can't find the actual detail of complaints, but in your summary does give us the stats that the 25-day response is 62%, which still means that nearly 40% of our complainants, public, what have you, are not getting a response within 25 days. And I guess it's a fairly general question. With the work that you're putting in, when do you see that turning around, I guess, as much as you can say?
There's a few things there. There is also something about how we are capturing some of that data. So, for instance, Karen, when I've been doing a little bit of digging and understanding a little bit more about the processes, if we're offering a meeting, our clock really should stop then until we've had our meeting, because we're not going to get the meeting. On the whole, you don't get the meeting within those 25 days because you need to ensure the clinicians are there, or the ward teams are there, and obviously it needs to meet a convenient time for the patients and relatives. So there's elements whereby we're having some data in this 62.5% that's not validated. What we are trying to do is really review what that process looks like so we can have a real clear trajectory, easy for me to say, when we are going to meet those targets. So currently it is all under review. We're just trying to ensure the processes are as streamlined as they need to be.
Sounds sensible. Thank you, Karen. And Tony, and then we'll move on.
Thanks, Chair. I guess this is a question for Ed. It's in relation to sepsis and EPR. It's a theme I've been following at various board meetings. I wonder if you could give us an update on how well you think that process is going in terms of automating our recording of patient condition. Thank you very much.
Yeah, so our sepsis and EPR work stream is being led by Dan Hastin, supported. He's one of our deputy chief nurses, and is being supported by Nick Fitton, one of our consultants in intensive care. So what we're looking to do is essentially model our response off Dudley Hospital's response. They've got the same EPR as us, and they've won national awards in terms of the way they've constructed their sepsis thing. So, you know, we're going to pinch with pride to a degree and try and emulate what they've done. It's not a straightforward lift and drop into our organisation because we're in different build versions of our EPR. So there's some technical reasons why we're not getting there in quite the same way that they have, but we're looking and being supported by them to create our EPR and sepsis patient. Isn't about sepsis, it's about the whole deteriorating patient, and in time will tie into other deteriorating patient initiatives such as the Martha's Rule initiative. So the work's coming along and hopefully be delivered in the new year.
Okay, thanks, Ed. And quickly, Hayley, because we need to move on.
Yeah, just to add to what Ed's saying, we've also got the training that's all been released, and that training's going really well, Tony, across the organisation. So we're tracking that training, and then hopefully, as Ed said, it will be online in the January, allowing EPMA to absolutely embed. And I know Rebecca's on the call. The plan is January, but our team should be ready from a training perspective. Thank you.
That's great, Hayley. Look forward to a further update after January. So we'll move on now to operational performance. And Chris, I know you're driving the engine and suffer I have to have very broad shoulders in that regard. Chris, how are you seeing things? What would you like to put out?
Thanks very much, Chair. Just a few bits I'll put out. I'm going to start, if I may, with cancer, and I'll come back to urgent emergency care towards the end. So from a cancer point of view, the improvements in our faster diagnosis standard, so we are back on track in terms of what we said we would do around our faster diagnosis standard. Board members will note that we're not on track for our 62-day performance though. That's driven by a number of specialties, but actually the focus in our recovery, now that we've recovered faster diagnosis standard, the focus now for me and the team is to reduce the number of patients that are waiting more than 62 days. So the recovery of the standard will take a little bit longer whilst we bring down the backlog of patients that are waiting. That recovery is expected and is on target to achieve in Q4 in terms of us delivering what we said we would do. it's been impacted mainly by specialties that we've talked about before in terms of skin cancer, breast and urology specialties. Skin's benefiting now from the benefits of the launch of teledermatology and also the launch of the one-stop service early in the new year in January, which will make that pathway for patients referred much quicker, which is really good for our patients. The other bit of positive news, I know I've talked to board members and you heard about some of this morning in the workshop, is the work that we've been doing with Gloucester and particularly with the specialist commissioners about potential to resolve what has been a challenge for us around access to tertiary services for gynae oncology, patients requiring surgery. So some positive conversations and hopefully some progress in that regard for patients in a collaborative way with our neighbours to the south once we work through the final bits with our commissioning colleagues. Around patients on the rest of our waiting list, so our RTT and elective waiting list performance, we do remain on track to deliver 65-week waiters by the end of December. Whilst that's taken us a lot longer than we wanted it to, I'm really pleased that we are still holding the line. We actually hope to be able to, well, we are on target to deliver that by the end of this calendar year. Around reducing the wait over a year, we have been challenged in three main specialties around ENT, oral and maxillofacial surgery and gastroenterology, but we've got plans in place for all of those services. So again, by the end of the year, we will be back on track around delivering our commitment around less than 1% of our waiting list waiting more than a year. But actually my ask of the teams is very much about nobody should be waiting more than a year in a modern health service. So we absolutely need to drive that number as close to zero as we absolutely can, because that's the right thing to do for our patients. So it is about going further and faster on some of the work we can do with that and how we optimise our capacity. I recognise that people may be concerned about that doing that over the winter period, but actually in most of those services we've got robust plans, and we historically cancel limited amounts of elective surgery as a result of winter pressures over the last couple of years because of the way we've configured our elective surgery. That does then really bring me to urgent and emergency care. And you heard from Stephen at the beginning about the significant volumes of patients attending our departments most recently. So from a statistics point of view, since the beginning of November, we've seen 15 days where we've seen more than the 85th percentile number of attendances attend the emergency department at Worcestershire Royal Hospital, pardon me. Unprecedented levels of demand with a number of days in the last week of over 300 attendances. That increase has been driven by people walking in rather than an increase in ambulance demand. So we have shared that information with our commissioning partners about what else we can do collectively to support patients to access more appropriate services to meet their urgent care needs. But patients are still waiting too long in our emergency department, too many patients over 4 hours, too many patients over 12 hours, and it is still taking us too long to enable patients to come into our hospital, to both of our hospitals when they arrive there by ambulance. But we do have some really positive improvements that we have been seeing at the Alex in that regard, but definitely more work to do on the Worcestershire Royal site. That said, though, a number of initiatives I do just want to make sure that board members are aware of. So the acute medical assessment area went live 3 weeks ago on both sites. That is seeing patients that are referred via GPs directly to acute admissions areas rather than going via emergency departments. The average length of stay in that space on both sites is about 12 hours rather than spending long times in our emergency departments before accessing acute medical units. More work to do in early days, but it's seeing positive impact for those patients. We have had the support of the eSister team, or the Getting It Right First Time Emergency Care Intensive Support Team, to review our ED rotas. We've received that report back, and we are in the process of realigning our rotas to the feedback of that review, so that we can make sure we've got the optimum number of doctors and other healthcare professionals available at any one time within our current funding envelope. And then the acute frailty unit on the Worcestershire Royal site is adopting a similar model to the acute medical unit this week, which is seeing limited impact given just the sheer volume of patients that we've seen this week. Other things to note in terms of patients leaving our hospital, though, we are continuing to work with Health and Care Trust partners and optimising what we call hospital at home or virtual wards in the community. At the moment, that facility is able to take nine patients, but is often now oversubscribed, and the capacity will move to 30 patients in the first month or two of the new calendar year once people have started in post as part of that service. All of that said, there are still 98 patients in our hospitals today who have quite no need to be in an acute hospital. So there's lots more we still need to do with our partners to get patients to the most appropriate place for their care needs to be met, be that reablement capacity in their own home or community hospital, or supported to return home through other means. That was all I was going to pull out of the report, Chair.
No, great body of work, Chris, but I do know it's very tough. Questions or perspectives to Chris? Colin?
Thank you, Chair. Chris, going back to cancer, you comment in your report about support we're getting from the West Midlands Cancer Alliance, which is great news, but will whatever support they're giving us be short term, and in which case can we sustain whatever improvements come from that ourselves?
Thanks, Colin, for the question. So the funding that's come through, so the West Midlands Cancer Alliance support, just for anybody who doesn't know, is effectively financial support for the organisation. It is, as you pointed out, Colin, mostly of a short-term or pump priming nature to enable us to put things in place. Now, some of those things are schemes of work we know are intended to be short-term. So they might help us to get over a hump in the number of referrals, or to do something very short term. But yes, a lot of it is things where we're trying to put things in place that we think we need. What we've been very clear about, though, is we then need to assess the benefits that we see through that, and there we will need to make an investment decision or not, depending on the benefits we see as an organisation for our patients, around whether or not those are things we choose to invest in the future, and how we then use the money we do have available in different ways to invest in those that do add benefit. Because on the whole now, where we are accessing funding through the West Midlands Cancer Alliance, they are very strict that it is pump primed and they won't continue to fund it year on year on year, which I think really is the right thing to do, because we need to put some of these things on a sustainable footing where they're a benefit to patients.
Okay, thanks, Colin. Thanks, Chris. Chris, keep up the strong efforts, and please thank all of your team for the next few weeks of particularly hard work. We're running a few minutes late, guys, so we'll try and pick up the pace a bit as I pass over to Liz. Liz, thank you for standing in for Ali. What do you want to pull out of the workforce section of the board report, please?
Chair, so we've got some positive metrics that we're maintaining in terms of our vacancy rate and our turnover rates, both of which are below our trust targets. What's that allowing us to do then, certainly for vacancies, is target our efforts from the recruitment team in some of those areas where we know there's a direct correlation with higher vacancy rates in certain staff groups and temporary staffing usage. So healthcare support workers is that area of challenge at the moment. We've got a specific target from NHS England to eradicate agency usage for health HCAs by the end of March, which we're committed to do and be able to achieve. And we're also taking a number of structured measures about reducing our escalated bank rates across nursing and midwifery. So we're targeting the recruitment now into the areas that really need it. We've got plans that are measuring our temporary staffing reduction, which is monitored through our monthly agency reduction board. And we're working closely with the Chief Medical Officer and Deputy Chief Medical Officer in terms of job planning, both in terms of increasing our compliance, but also the robustness of the plans, ensuring consistency across the divisions and specialties, and moving to the goal is to move towards an annual approach to job planning rather than it be on a consultant by consultant basis. So they're the main highlights. Happy to take any questions.
That's really clear. Thank you, Liz. Any questions or perspectives to Liz on workforce and people? Had some great discussions, Liz, on culture this morning. So you might want to watch the video of this morning's workshop just to help you. Okay, so obviously with how busy we are and the level of corridor care we've got, the numbers are quite challenging at the moment. Neil, what would you want to pull out of the numbers, please?
Yeah, thank you, Chair. From a positive perspective, at month 7, we've reported a break-even position, very much largely, again, reliant on some non-recurrent benefits. So we've added a further 4.5 million from the balance sheet to offset the challenges in month 7. So in month 7, back half of the year, board will be aware that the CPIP challenge is £3 million a month. So we've been able to offset that in month 7 with non-recurrent measures because we're not seeing the traction on the CPIPs that we need at this point. So we've offset that with non-recurrent means. Added to that, of course, given the context that's just been set by Stephen and Chris, very busy operationally. Those costs of excess capacity are feeding through into the position as well. And of course, some of those were supposed to be removed in month 7 in line with the plan. So again, that's an added pressure in terms of the bottom line. We've pretty much exhausted most of our non-recurrent resources at this point. So we've set some revised control totals for divisions, some challenges around getting back on track financially, particularly aligned to some additional income opportunities that may exist through doing some more activity to improve our waiting list figures. Just wanted to point out in the report, just from the perspective of the CPIPs, you'll see there that we are now reporting on plan with respect to CPIP. So to be clear, that's because we've been consistent with others and started to record the non-recurrent benefits, the non-recurrent savings, the money from the balance sheet against our CPIP. But you'll see there from the CPIP slide that we're still challenged in respect of moving the opportunities into plans. So much more focus and effort on those in the next few months is required. The other thing I just wanted to point out is in respect of the cost per weighted activity unit. You'll see from the slide, it's heading in the right direction. And this is great news in many respects. However, given that we are reliant on the non-recurrent benefits and they're adding to that reduced cost or offsetting the increased cost, should I say, they're featuring as the cost per hour, making those improvements. So in order to keep that on track for the remainder of the year, we do need traction on the financial recovery actions. Just to touch on cash, cash at this point, we're still liquid. It is going to become more challenging as we enter the latter part of the year, unless we get traction on those CPIPs. Happy to take any questions, Chair.
No, we note the caution in your voice, Neil. A question, some perspectives to Neil. Colin?
And on the subject of productivity and performance, you comment that the costing team is working with the divisions to identify opportunities for improving productivity. That sounds a very promising line. To what extent are we sufficiently resourced to maximise the opportunities out of that? And what are the sort of things that they're helping with?
Yeah, so we've now got national benchmarking information around our cost collection, so we can benchmark with other organisations. So it is a small costing team. There's a couple of individuals who've provided information to the divisions, walking the information through with divisions around where we're an outlier compared to other organisations and what's driving those costs, those higher costs compared to other organisations, to try and get some traction on how we might make some of those changes to reduce our cost base.
Okay, thank you, Colin. And any other questions to Neil? Okay, we'll move on then, recognising the caution in your voice, Neil, to the safe staffing report. And first up is Justine on Miss Whiffery, please. Justine.
Thank you, Chair. So safe staffing for October report. Take the paper as read. Just wanted to highlight we were safe on all shifts. unfortunately you'll see there that the sickness has gone up slightly in month, but pleased to report have had sight of the November figures, and in both groups they're now below 5%, which is really encouraging. Red flags met, lower acuity was met in October, a very busy month. I did talk at the last meeting around a sustained peak of activity, and we remained in that sustained peak and still do. We did have to rely on some movement of our community and continuity staff to support the inpatient area. You'll see there that there is an increase in the number of staffing incidents reported in month, and what's driving that is sickness within the Band 7 cover, and that has been reported consistently throughout the month, but that is an improving picture. Also, in terms of the medication errors, you'll see that they're predominantly in our postnatal ward area, and what we have done is started to pilot a slightly change in our roster template with more trained staff in the day and a slight reduction at the night time, which is offset with an increased level of support worker overnight. So we should see those come down. Nothing else to report this month, thank you.
No, thank you, Justine. And Justine, just before I invite questions or perspectives, obviously Baroness Amos has published initial findings and has commented on her anxiety about a number of maternity units. I'm pleased to say, under your leadership, the maternity unit of Worcestershire has been rated as good, as are all of the maternity units across the foundation groups. So thank you for your leadership in this regard. Any questions or perspectives to Justine on the safe staffing report on midwifery? Okay, we'll move over then to Hayley on nursing. Anything you want to pull out, Hayley?
Just a few points, but I'll take it as read. So our fill rates remain above 95%. Our care outpatient per day remains stable, and we are agency cap compliance. In terms of agency, we have, as Liz mentioned earlier, a plan to eradicate healthcare support worker agency out of the organisation, but also RN agency as well. That is a very planned, measured approach, though, between now and the end of March, and it needs to go in line with capacity, vacancies and sickness. So that goes through one of our operational meetings, but there is absolutely a very clear plan to eradicate agency. Our RN vacancy rate is improving, so we've got a really good picture there. And we are also part of the Enhanced Therapeutic Observations cohort that is looking really how do we support our most vulnerable patients in the organisation. Years ago it was called specialing, it's called something different now. So we are absolutely working with our NHSE colleagues, learning from other organisations who have done it really well and seeing how we can absolutely bring that in our organisation. Moving forward, and we agreed at Quality Governance Committee, and I know that Sue and Simon are on the call, is the report might look slightly differently moving forward. We're looking at, can we get something that's a bit more intuitive and having probably clearer triangulation. So I attended a national webinar probably about a month ago and saw some best practice. So we're going to trial some different reports coming to QGC and ultimately here. But I'm very happy to take any questions. Thank you.
Thank you, Hayley. Any questions or perspectives to Hayley on the Safe Nursing report? Stephen?
Yeah, Hayley, I was going to ask about the bit about the enhanced therapeutic support. Wasn't going to call it the other name. We've talked a few times, and I know we've talked to Natalie at the Health and Care Trust about getting some expertise in around that and helping it. I know the trust do. Can we pick that up and accelerate that? Because
yeah, absolutely.
I'm just thinking for board members, it's not just a cost issue. I really worry about patient experience of having somebody, for example, sat with you constantly, and the fact we're making it a registered mental nurse in a lot of cases. I just worry about the patient experience of that as well, given the numbers that we can do. So if you could just pick that up.
Absolutely. And there's a lot we can do in that space. So you're absolutely right. It's our patients with mental health conditions. It's our patients with dementia. There's a lot of work that falls under that umbrella. And also there's some work that we need to do with our teams about how do we support them to give our patients the correct interventions when they are supporting them. As you said, Stephen, it's not a case of just sitting there and watching. It should be therapeutic interventions. But yeah, absolutely. Thank you.
Well, Stephen, your experience in this regard is going to be very helpful. Thank you. Okay, Tim, we'll move on then to the maternity reports. And first up is the perinatal safety report, all 29 pages of it, Justine, which obviously was read. But what would you care to put out?
So, yes. Thank you, Chair. So this is a slightly redesigned report based on the perinatal quality oversight model rather than what was the perinatal surveillance model. That was implemented in August. So you will see within the contents page, we thought that would be helpful to have and highlighted the new additions in blue so that you can see the extent of the information that is now being requested. Hayley and I have had a conversation and looked at some other examples because obviously this is becoming quite a large report and very difficult to digest and also takes a considerable length of time to prepare, but we will try and make sure that it is as valuable as we can do going forward. So the only things that I wanted to pull out this time was we have changed the booking by 12 weeks. It's now booking by 14, and you'll see there that we have a little way to go to meet that KPI. However, we do need to confirm what the national target is because there isn't one currently. And I think we're being very ambitious, but we should always try and stretch ourselves. You'll see there also that our perinatal mortality rates remain lower than the national rate. Sadly, we did report a neonatal death and stillbirth within this quarter. You also have noted previously from previous MNSI reports where we've reported babies who have sustained HIE that we have recently moved from standard CTG monitoring interpretation to what we call physiological CTG interpretation. And already we're seeing some really improved outcomes for babies because of that change in practice. So we're really optimistic that you'll see that the number of babies reported with HIE has reduced considerably over the last few years, that will continue. So that's really good news. Great to see the net survey information required within the report, and also happy to report that the midwifery scores have improved, and a paper did go to People and Culture around the improvement in student midwives' experience with us. There's a CNST roundup there, but I have got a paper on CNST also, and things are looking generally positive. Happy to take any questions, Chair.
Thank you, Justine. Any questions or perspectives? Stephen, your hand went up and then went down, gone back up.
Yeah, no, I was a bit early. I think one thing for Justine Hayley to have a think about, and you alluded to it, Justine, I'm really conscious with all the national media around it. If you take this report, we understand it because we see it a lot, but if I was a mother or somebody looking at it from the outside, I wouldn't know where to start with. What should I worry about and what should I not? So I just wonder if there is something about a piece of work, maybe with our midwives and our staff in there, plus mothers, of what would mothers really want to see? And I'm always struck by the staff know what to worry about. Our staff know what to worry about. So how do we bring that into it that simplify? We might have to report all this, but even something at the front so we could just look at it and make sure they know we're focused on what they're worried about and we know we're safe. So it's just a thought, maybe take away and have a think about.
I think that's a very good thought. I mean, obviously we need the detail, but we can pop that into the appendix. But it was a similar point to the one I was going to make, Stephen, which is, you know, again, for members of the public who might be watching this for the first time, as your chair, I have three ultimate priorities in my view. The first of which, in terms of the work we do as a trust, the first of which is to bring life safely into the world. And so I know Sue Sinclair is on the call as well, and I are absolutely passionate as non-execs to help ensure that's the reality. But as as Stephen's indicated, Justine, I think if we can make it a bit more digestible, I know you're directed in this regard, but if we could think about even an executive summary and we pop the rest in an appendix, just to make it more digestible as it is for the public consumption. Any other questions or perspectives on the two papers from Justine? Not so much for you, Justine, but I think for a future board piece of analysis, Stephen. We do pay £10 million a year as our contribution as a trust on maternity premiums into the clinical negligence scheme, which Justine's paper covers. That is an enormous amount of public money being put away. Now, our premium at Worcestershire is the highest relatively in the foundation group, which I assume goes back to issues like the Wye Forest birthing centre issues of about 21 years ago. But we should understand what's driving our very high premiums. So if we can take that away, Stephen, not so much for you, Justine, because I think it's more a finance thing, to understand why our premiums are so high and whether they're about to fall down, given the sort of 20-year rule on maternity claims, and if so, when they drop down, or if there's anything we can do to help by investment in maternity or paediatrics to get those premiums down faster. I think that's an interesting piece of analysis in that. Justine, thank you. We'll move on to the board committee reports then. The first up is the Quality Governance Committee. Sorry, Justine.
Apologies, Chair. There is a CNST report as well.
Sorry, I thought you mentioned that in your summary, but okay, back with you.
Sorry, just needed to just report for the purpose of the minutes that we are on target for 10 out to declare 10 out of 10. You'll see the PMRT reports within the report, and I do need to highlight that they were graded A and B. So there was learning only here to share with the team and the wider system. And also recognition that we met the requirement around locum induction. Just wanted to also, for the purpose of the minutes, is to highlight the process now in the run-up to completing the board declaration. Hayley, myself and our compliance midwife will meet in January and look at the evidence line by line. This will then be presented at QGC. We will then bring a summary presentation to board in February ahead of the declaration time. Thank you, Chair.
Thank you, Justine. Sorry, as you mentioned the CNST report in your earlier comments, I thought you'd covered what you wanted to. Any questions on what Justine's just said? Okay, clear time frame, thank you. And you get the thumbs up from Hayley, which is always helpful. The board committee reports then. First up is the Quality Governance Committee. We have apologies today from Dame Julie, but I will take those as read. Any questions on those QC minutes from October? And thank you for colleagues who sit on that and all the hard work that goes on behind the scenes. We've then got the Audit and Assurance Committee from November. A couple of pages, Colin, there. Anything you wanted to emphasise?
Thank you, Chair. Happy to take most of it as read. The one aspect I'd like to draw the board's attention to is a very informative report we had on the implementation of our EPR system. The overall message was that it was an incredibly successful completion of a very challenging task to introduce this type of system. Not many trusts reach the sort of level of satisfaction that we've been able to reach, but there are a couple of aspects that we wanted to have further conversations around, starting with the fact that the total cost so far of the project is about 3 million over the full business case, and we felt that there was need for a scrutiny at board level of this type of increasing costs. We were assured that the individual items which contributed to that increase were all looked at in some depth, but nevertheless we thought board supervision was important. And the other thing we talked about was the realisation of the benefits included in the business cases and the challenge that all organisations have of translating those benefits into realisable cash impact on the bottom line. And that's something we feel merits increased supervision, keeping a watchful eye on. That's all I wanted to say. Thank you, Chair.
Okay, thank you, Colin. Great to hear about the smooth implementation. Well done, Rebecca and team on that, and I'll take on board your point on the benefits. In terms of the overspend, that's the first time I heard that earlier today. Neil and Stephen, can I ask you to come back to the board? I don't understand how we can spend £3 million more on a project and it not come back to the board for either review or sign off. And I can't remember it coming to the board. It may have been before my time. But can we take that away, please, and come back to the board for the February board? Thank you. Any other questions to Colin? Okay, we've then got the People and Culture Committee. Karen, anything you want to pull out of these notes?
Thank you, Chair. I'll be brief and take it as read. We've reported previously on a piece of project work around fatigue management, particularly looking at the way that might impact on our night workers. That work continues at a slower pace than we'd like, but just to say that we're now picking that work up as part of the overall health and well-being work plan that we've got as an organisation, rather than something separate, so that all of those contingencies can come together. Many of the other items we've actually already covered today: job planning and reducing agency spend, and the committee feel, I think it's fair to say, more assured that we now have stronger controls and monitoring processes in around both of those two challenging areas. Apprenticeships we've seen and heard about today already, and the success that we're having as an organisation there. We've subsequently had a meeting on the 2nd of December where again we discussed the importance of the flu vaccination, both for our staff and the local community where that's appropriate. So put some encouragement there. And the only other thing I would raise from the most recent meeting is we had a staff story, which was pretty much a patient story, but we looked at it was about a transgender patient, and we looked at it very much from the angle of how we need to put some more support and help in for our staff in terms of dealing with some of these challenging day-to-day situations. But that will be covered more in the minutes next time.
Thank you very much, Karen. Thanks for your hard work in that regard. Any questions or perspectives to Karen? Okay, thank you, Karen. Well, one of the medium-term challenges we have is the PFI exit. We've got a PFI exit committee going on, chaired by Tony Bramley. Tony, anything you want to add to your update?
Thanks, Chair. Just a couple of points, if I may. The first is I'm pleased to say that the pace has picked up with this meeting, and we're now starting to get some concrete plans in place, and we can see our way being mapped out for the rest of this calendar year and into the next business year, which is good to see. I would just draw the the board's attention to the comment under the condition survey bullet point, because one of the things we will be looking for early in 2026 will be approval to arrangements to conduct this condition survey, which is critical to our preparations on the exit, and that will require board approval and a special meeting of the committee, which might call for a single item board meeting early in 2026 with your approval. Thank you very much.
Of course, Tony, it's important to get that condition report done as quickly as possible and agreed. We've done the similar thing down at Wye Valley, where we're on the glide path to exiting the PFI, and that's gone very well down there, so hopefully it will with us as well. Any questions or perspectives to Tony? Okay, well, it's good to see Melanie on the call as well. Liz and Melanie, what do you want to pull out of the Freedom to Speak Up Guardian report, please?
So obviously I'll take it as read, just the main highlights. So we're continuing our downhill trend of anonymous concerns. That's really good, because at one point we were sort of half of our concerns were anonymous, but we're now down to 25%. Things really are for me, the increase in neurodiversity concerns. That's one that I know I've highlighted already at numerous committees, and racial concerns. We've seen a spike in those, but there's no trend as to staff on staff, patient on staff. It's across the board. So we continue to work with the networks to try and address those and reach the staff that don't approach us. And Carol and I continue with our walkabouts, trying to reach those staff so that we're visible and that they come forward, because we know there's barriers in certain areas, and those are the people that are less likely to speak up. I think that's it for me. Thank you.
Thanks, Mel. Any questions or perspectives to Mel? Stephen.
Yeah, I think it's more of a comment really, and I think it's one that we're keeping close to. So I think in the executive director opinion it does reference. I think with the national changes, one of the things that's come through is, particularly for Freedom to Speak Up, is the crossover where people may be in kind of either HR processes or in other processes, and it's not necessarily directly relating to safety. It's more of a concern that they have. I think it's important that we've got routes for them to listen to, so Mel and others that support them. But I think it's just for us to be mindful of. I think that will evolve, and I think that's the mood music we're getting from the national team, that, you know, some of these things have crossed over, blurred a little bit, so we need to maybe just reset them back and be really clear. And I think we'd have to be really clear with staff as well that are getting used to these things now, about that's actually the reset that we've got to do and try and manoeuvre that. So I think it's more for board and public awareness, not necessarily a comment on the report.
No, point well made, Stephen. And it is important for members of the public and staff who listen to the board digitally, that the board is absolutely committed to creating a safe environment for you to feel very safe, just to speak up on anything that causes you a concern, particularly on patient safety. But if you're feeling bullied, harassed, undermined, mistreated in a way that you don't feel you can approach your line manager on, please, please, please speak up. No one has the right to make you feel undermined or belittled when you come to work. No one has that right. And you all have the absolute right to speak up on any issue that you want to, and you will get the board's full support to do so. We will endeavour always to create safe spaces. I would just encourage you to be brave and speak up. Okay. Mel, thank you for your work. Liz, thank you for your oversight. I look forward to seeing you again next year, Mel. Okay.
Thank you.
And we'll move on then to the board assurance framework. And Gwenny, over to you.
Thank you. Yes, presenting this in its new format, as previously agreed, with more focus on actions and assurances. We have a separate risk summary for each risk. Those will develop over time, and we're likely to add some further risks, including one about the PFI programme. We've also got a headline summary there for all of the risks, and they've all been aligned to both the Trust strategic priorities and the relevant ICB objectives for additional information and assurance. This will be going to the Audit Committee, which has a responsibility to review the format and process surrounding it.
That's super. Thank you, Gwenny. Colin, do you like the way it's looking in its new format as Chair of Audit?
Yes, I'm very positive and supportive, Chair. Gwenny and I have had several conversations about the direction of travel. I think it's the way to make it more meaningful, and in particular assist the committees of the board in exercising their oversight responsibilities. So yeah, I think it's good progress.
Okay, thank you, Colin, and well done, Gwenny. Any questions or perspectives to Gwenny on the BAF? Okay, Christmas is coming, the goose is getting fat, and we've got the biannual register of the SIL report. Gwenny, which will take as read. Anything you want to add to it?
No, thank you. That's taken as read. Thanks.
Any questions on the SIL report? Okay, well, We are always enormously thankful to the Charles Hastings Education Charity for their support of us as a trust over decades. But in terms of the update, Tony, what would you like to pull out?
Thanks, Chair. I think it's fairly self-evident from the report. I'd just like to draw the board's attention to one item in relation to the clinical simulation facility, which has got its funding with a very generous charitable donation plus funds from the Charles Hastings charity itself, plus a lot of support in a practical and technical sense from our trust. The great news is this new simulation facility should be up and running very early in the new financial year. And I'm led to believe, having seen some AI representations of what it's going to deliver, it'll be one of only 3 augmented reality clinical simulation facilities in the entire country, and looks to be absolutely state of the art. So I hope we'll get an opportunity as a trust board to have a look at it when it's up and running. But great news for the trust, I think, on the back of Charles Hastings' achievements. Thank you.
No, absolutely, Tony. Well said. Any questions or perspectives to Tony on that update? So we're meeting again on the 10th of February. Stephen, obviously, as the Chief Executive, will be briefing the board throughout the winter Christmas period and New Year period on how we're performing. But any other business colleagues, could you raise a digital hand for me, please? I don't think we've had any questions from members of the public. Have we got any?
No, I've received nothing.
Okay, I would just encourage members of the public or staff who are watching this remotely, please don't hesitate to ask the board any question you like. And that's what we're here. We're public servants and we're here to serve the public and to be transparent in everything we do. So we'll draw this meeting to a close then and suggest we take a 10-minute break, meet together at 2:15 for the confidential board, and I'll try and save the executives some time. Thank you, everyone. Take care and Merry Christmas.
Thank you so much.